morning. This is just basically what we're going to talk about, framing the issue, why we make the case for integrated care management, what we found with HEDIS and CAPS results or satisfaction results for people who were involved in the Synergy Disease Management Program. Sam's going to do a little song and dance about what the program is and why it works. And I think actually he raises some extremely good points. But let me start with just a brief introduction about who we are at CareOregon. I think, based on my number of years of doing this, that we have a fairly unique program. We started in 1994 when the state of Oregon came out with what's called the Oregon Health Plan, which is the Medicaid plan in the state, based on a prioritized list of covered services. So a group of people in a very public process sort of looked at all healthcare services, and then they looked largely at the evidence and figured out what made sense, and from a population perspective, what does the state of Oregon want to pay for its Medicaid population? So for example, the obvious one, cosmetic surgery isn't a covered benefit, but they actually ranked the relative value of all healthcare services. And then through the legislative process, dependent on the amount of funding available, a line was drawn. So I don't know where the line is today, something like line 498, and everything that's listed that pairs, diagnosis and treatment, that pairs above the line is considered a funded benefit, and anything that's below the line is non-funded and not available to the population. So to simplify it, I think it's actually a very rational, rationed healthcare system. And it is a good benefit. And there's a public process to sort of determine what are the criteria for paying for services. And it's an evidence-based public process, so we don't have to have our own technology assessment process, which is great. So CareOregon was formed when a couple of the public health departments and Oregon Health and Sciences University got together and said, how are we going to manage this? We've got all these people coming onto this Medicaid program and we have no way of managing it. And that was the birth of CareOregon in 1994. Am I getting this right, Claire? And it was founded really as a socially oriented health plan, and frankly did not have well-defined processes, well-defined oversight, and so a few years later found themselves about $36 million in debt and down to 48 hours of cash on hand. And guess what? The board changed and the management team changed, and since then we have been phenomenally successful. Which from my perspective is really an indication of the amount of waste that exists in the healthcare system. It's a challenge because our success was based on really understanding the business and managing it, but also really managing the benefit. And now we're trying to move away from that, which is makes us a little nervous. But we have historically been a Medicaid plan with approximately 170,000, maybe now 180,000 Medicaid recipients. In 2006, we developed a dually eligible SNP plan and now have approximately 10,000 members in that. We no longer have any direct Medicaid members, so we're no longer a Medicaid plan because the state has gone to coordinated care organizations, which are community-based organizations operating under a global budget which encompasses physical health, behavioral health, dental health, under one budget. It's a big challenge. Managed through a local board of directors with a local community advisory committee and clinical advisory panel, and who by contract with the state have a transformation plan they need to deliver on and incentive metrics. So we are intimately involved with 4 CCOs, but the members are no longer ours. They now belong to the CCOs. So that's another story. We got involved with the Synergy Disease Management Program in 2009. And it was because, frankly, we decided we wanted to become NCQA accredited, and we didn't have the bandwidth to do a disease management program on our own, and Health Integrated had a program that was NCQA certified. And so it met our needs. And we had been working with Health Integrated in other areas for a number of years. And really, I was very drawn to the biopsychosocial holistic approach that they have to managing members. It was very consistent with what we're doing with our telephonic case management program, but for a broader population. So it met our needs. We have, as you can imagine, a very challenging population. Our Medicaid members have always included the ABD population, so it's not just moms and kids. We have a very high incidence of substance abuse, chronic mental illness, low literacy, lots of homelessness. I mean, it's your typical Medicaid population, unfortunately, and presents lots of challenges. So really, we had no option but to find someone to help us do this, and Health Integrated was the group we chose. Tom talked me into it. I said, okay, we'll dabble with a very limited population and see what happens, and since then we've expanded the program to make it available to many. I have had experience with other disease management vendors that are disease-based vendors, and I absolutely refused to take that route because it just didn't meet the needs of our population. If you're trying to help manage a patient who can't read, who doesn't have a home, who has diabetes, and you spend your time focusing on eating appropriately, measuring your hemoglobin A1C, drug adherence, they can't hear you and they can't respond to it. You've got to start with where the patient is and what are the needs of that individual person to be able to move them toward the appropriate management of their disease. So as most of you probably know, the Synergy program identifies the population for management by their diagnosis, but the approach to the management of the individual is really a holistic approach. It's not a diagnosis-based approach. The other thing that really I appreciated a lot was the willingness and basically the fundamental design of the Health Integrated program, which integrates with the work we do at the health plan. So things are branded, I believe, with both our names. I think the greatest asset that this program brought to us was one of the Health Integrated staff actually embedded, and he has office space in our building and works with us. His job is to get out into the community, develop a presence with providers. He does outreach to members. He will go meet them in physician offices, sometimes in hospitals. He'll identify their needs. He'll find resources for them. And it makes a huge difference in terms of really having a presence and a very close working relationship. There are also weekly case conferences. One of the challenges is that I consider the disease management program part of the spectrum of services we have for our population. And so you've got that interface, that gray zone. Sometimes people are really sick and need the more intense case management services. Sometimes they need personal on-site services. But at some point, they're going to get better, and the amount of support they need is going to be less. Similarly, some people who are in the disease management program may get sicker and need more intense services. So there are regular conferences that occur between the Health Integrated coaching staff and our case management staff to sort of deal with those individual cases and ensure that people are receiving services that are appropriate for them. I've not seen that with other programs. Of course, I don't know all the programs, so I don't want to. Anyway. How do you measure what didn't happen? That's the fundamental question that we bumped into. And lots of people, including Health Integrated, have methodologies that they propose as effectively measuring a return on investment. It was very hard for me to get our analytics group and our CFO and consequently our CEO to say, yeah, we buy that number, it makes sense. And so we frankly spent way too much time working back and forth between Health Integrated and CareOregon to validate numbers, validate methodology, and probably there were issues on both sides. We just couldn't get there. And I got a little frustrated, and I was looking at all this time being spent, which meant our limited analytics staff wasn't available for other things, and I said, stop. I don't care what the return on investment is. That caused a few hearts to stop, and I said, you know, at CareOregon for years, we have had the triple aim as our business plan. So in theory, we are as focused on the cost of services and hence the return on investment as we are on the outcomes, both in terms of health outcomes and experience of care outcomes. And so I said, let's look at these. Let's look at the other two. I mean, we've got people engaged with coaches. We've got people receiving mailings. We should be able to figure out if it makes a difference, other than, is it saving us money? I think you swallowed hard, Tom. You know, because it was sort of challenging your business model also, in addition to ours. So we have a relationship with Portland State University and a sociology professor there who's done a lot of work with us over time. And so we got in touch with him and sat down and said, this is what we want to do, can you help us? And he did. What Matt Carlson did was to put together a telephonic survey that was a validated survey tool and did enough outreach to be able to interview 50 patients. And what he said was after 20, we knew what they were going to say. And so they assessed the experience of care. And frankly, we're always challenged to improve our HEDIS outcomes and our CAPS outcomes. We don't get good results. We have great processes, but the outcomes from a population perspective are really hard to get with this group of individuals. So he did a telephonic survey of 50 members looking at their experience with the health coaches and whether or not the patients' members felt that those experiences had any impact in terms of the way they dealt with physicians, whether they took accountability for their own health, and basically, was it a useful process? What did they think about it? And then we took our HEDIS data and sorted it by CareOregon in general, those who received mailings from Health Integrated, and those who received coaching from Health Integrated through the Synergy program. The results are really impressive, I think. I was surprised. I suspected we'd see a difference, and I know we had looked previously at HEDIS outcomes sorted by people in coaching, not in coaching, and had found what appeared to be a significant difference in terms of outcomes, but it's one point in time. So this study really showed pretty much in a global way, except for some of the behavioral health results, improved experience of care and improved health outcomes as measured by HEDIS. And interestingly, the HEDIS outcomes were better even for those only in the mailed program. But again, there are lots of caveats in this study. You know, it's a point in time. If we were to try to really prove this, we'd have to look longitudinally with a control group and see if, because people who choose to participate in the program may be more motivated at baseline. But still, it was enough to satisfy my CFO and CEO. Here are some of the results. Areas covered in the survey: preparing for communication with physicians, finding the best physical exercises, determining the right amount of exercise, making good eating choices, coping with limits to daily activities, confidence managing health. That one's really impressive in terms of the outcome. The first column is the percent of the recipients who remembered discussing the issue with their coach. And then the second column is the percent who were satisfied with the experience or felt that it helped them. So if you have 90% of this population reporting confidence managing their health issues, that to me is a significant finding. Setting health plan goals with the coach. And then there was some overall satisfaction with the program questions. Frequency of the coaching sessions, overall satisfaction with the coach and the coach's impact, and whether or not the program made a difference. So I think I was very pleased with these results. Let's let Sam do his piece of this and then entertain questions.
We're going to talk specifically about what it is that was done in terms of the integrated care coaching. what is integrated care coaching? You've heard mention of Synergy, the Synergy program, and so forth. And so the approach here, what's interesting about these results, we were so pleased to see these outcomes, obviously, but it actually made sense to me when considering what it is that our coaches do with the members. The focus is to look for those members in the population who are at high risk, but for a very specific reason. They're at high risk because of underlying psychosocial drivers. Psychosocial drivers can be a lot of things. It can be a major depressive disorder. It can be a generalized anxiety disorder. It can be a substance use disorder. But it can also be maladaptive behavior patterns. It can also be social isolation, etc. And we data mine for all of these things, but of course the data mining is what I would consider the broad net that we cast. Once we get someone on the phone, we conduct a very thorough assessment to validate that those underlying psychosocial factors are really there. Does this person appear to have some symptoms of depression or anxiety? What is their coping skills and mechanisms around their stressors? And how does that relate to the disease burden that they have, which can be a number. In fact, the average number of comorbidities that we identify in the Synergy program is about 4 or 5 physical illness morbidity. So it's real important. This slide, real quickly, just demonstrates the relative cost and utilization for members in the population with or without behavioral health comorbidities. And here it's clear that if there are behavioral health drivers, or whether it's psychiatric or substance use, the overall utilization of healthcare resources is higher. And this is something that I think we've been seeing in the literature now for a number of years. Again, patients with medical comorbidities have higher incidence and prevalence of psychiatric comorbidities, and that multimodal impact creates a higher need for healthcare resources, higher healthcare costs, contraindicated behaviors. People generally don't do what's in their best interest from a behavioral perspective, from a nutritional activities perspective, from a adherence perspective to their treatment plan. And let's face it, some of these psychiatric illnesses actually impede or cause a negative impact to the response to the medical treatment plan. There are actually biological markers and indicators that show that there are changes in not only the central nervous system, but throughout the body that can make these very negative scenarios, not just from a behavioral perspective, but from a pure biological perspective, hence biopsychosocial. So what we target then in these populations is we're looking for that group of people, and this particular slide references 7%. It could be 7, it could be 10%, it could be 12%. It will vary based on the population mix and type, but we're looking for those individuals that we have a high suspicion of an underlying psychosocial driver, who certainly are burdened with physical health conditions. And here you can see in this particular slide that we're representing that those people, although they're a small percentage of the population, are driving a significant portion of the cost for that plan. So what is integrated care coaching? What is Synergy? It started out probably about 10 years ago as a depression disease management program. The idea was, let's look, and it was when, disease management, we had asthma programs, we had diabetes programs, and so we thought, well, wait a minute, no one's really addressing depression. We're hearing a lot about it's important to identify depression, it's important to screen for it, but what struck me as a psychiatrist, that plans were screening all over the place for depression, then once they found that it was there, what next? There was a lot of disconnect between what do you do then once you find depression. So we said, well, let's put a disease management program together that identifies the population as having depressive disorders, and then coach them. Let's educate them. Let's talk to them about their barriers. We found that it had tremendous impact. We actually published a couple of studies on this, and we thought, the outcomes seem to be what we would think as medical cost offsets. In other words, we're managing the depression, but the true outcomes are in improved behaviors, improved utilization patterns. And so we thought, well, let's not just limit this to depression. This really needs to be broadened to all of the varieties of psychosocial illnesses and barriers that anyone could possibly have. Is it substance use? Is it maladaptive behavior patterns? That's what became what we call synergy. And here's a brief description of what that is. We start with the identification of the population. We do look at claims data sets, but again, that's a broad net. That those claims data sets tell us who we think there's a high level of suspicion for an underlying psychosocial issue, but it's not necessarily definitive. It might be definitive. We might find a certain percentage of these members to have major depressive disorder or bipolar affective disorder or any number of definitive diagnoses, but we're really looking for those people who are falling between the cracks. Who are those people? Those are people either with undiagnosed behavioral health or psychosocial drivers, or that have been diagnosed but are not optimally treated because they're not receiving treatment in the behavioral health provider environment. They're receiving their treatment where? In the primary care environment. And we all know that PCPs are burdened with so many responsibilities and the time is so limited, and their training is also limited in terms of making an appropriate, effective diagnosis. And a lot of PCPs are a little bit skittish about treating patients, especially when they need to push dosages of medications, refer patients to psychotherapy. And let's face it, there's a lot of stigma, unfortunately, still out there. So this is the broad net that we cast. We then need to validate that our suspicions are correct. And that's done through the engagement process and the assessment process with our care coaches. Who are the care coaches? They are typically master's prepared psychotherapists. They are the front line. These are independently licensed clinicians who come to us already with a background in training and understanding psychotherapy and psychopathology. They've been trained to implement cognitive behavioral therapeutic techniques, any number of psychotherapeutic techniques. We get them in our call centers and we train them on the program design, but we also provide them with an infrastructure in our information system that focus on the physical illnesses, so whether it's diabetes or asthma or COPD, so that provides them a framework and assessments, the appropriate questions to ask around this. And then we also provide them with in-service trainings on a regular basis around the physical illnesses. They then have the availability with our physician medical directors to consult with our docs, to consult with other nurses in our call center around particular issues. But what do they do that makes the difference? And why was I not terribly surprised around the results that Margie presented relative to satisfaction, relative to changes in HEDIS numbers? It's because what they do, instead of asking members about, did you go and get your A1C? Have you had your retinal exam? Did you do X, Y, and Z according to the list of things that we all know should be done? It's around identifying what are those barriers. Why is this person not responding to treatment the way that they should be? Why aren't they adherent to their treatment plan? Oh, maybe this person has an underlying anxiety disorder. On top of that, complicated by some somatization disorder, perhaps. Maybe this person is getting some secondary gain from maintaining the sick role. I've seen that many times with diabetics. The diabetics utilize their illness for secondary gain, and they can just be on a spiraling merry-go-round out of control, cost, utilization, and then secondary comorbidities. So the care coaches identify what those barriers are and begin to work with those members. And these calls are not 10-minute calls. These calls average 35, 45 minutes in length, not unlike a psychotherapy session, not unlike psychotherapeutic interventions. And in my opinion, there's a high level of psychotherapeutic value, even though technically, formally, they're not rendering therapy. They could, they're licensed to, but it's not what they're doing. They're coaching, they're educating, they're motivating. They're getting these people they're coaching, what I call coaching to and around the barriers. They use tools like the PHQ-9 to identify levels of depression, other tools like the PTSD checklist, a number of tools they use, as well as those physical illness assessments, to understand where this person is and then to begin to work with them using very specific techniques like cognitive dissonance and cognitive reframing to change behavior to a much healthier direction. And that's why I wasn't astonished. I was pleasantly surprised, but I wasn't astonished to see the outcomes because, in fact, just as what Margie said, and saying it a little different way, when you do the right thing, you engage people who need that attention, who need that redirection, then you can make a difference in terms of their overall behaviors, which are going to improve all kinds of things, including satisfaction and including HEDIS scores. So the empowerment piece is around those motivational interviewing and cognitive behavioral interventions. Then you measure the results. And we measure results looking at, certainly at utilization patterns and at cost patterns. But now, thank you, Margie, for showing us that we should be looking at other metrics, like HEDIS metrics, like satisfaction metrics, because they, in fact, those needles move too. And there are probably other needles that we haven't really even begun to explore yet that show us that they move. The coordination of care and the connect piece down at the bottom is what Margie referred to with our outreach coordinator who has an office at the plan. Very important piece of that. We're working with these individuals in a very intense way. The calls are scheduled. And then again, there is the outreach component. So there's a field-based component to this. In fact, Peter Dean, who is our outreach coordinator at CareOregon, actually visits members in their homes and actually does a lot of great work, and he's a clinician also. So we want to have that field-based component mixed with the telephonic model to achieve the best possible outcomes that we can. It's a deep biopsychosocial approach to understanding where those members are, what are the barriers that they have, how do we coach to them and around them and get them to a much healthier place with lasting behavior changes. And I'll say I don't have data to show you right now, but we've looked at a lot of data sets to say, well, is this long lasting? Does this actually stick once a member has been through a coaching program for 9 months or 12 months and now they're graduated? And the data highly suggests that these behavior changes are very long-lasting and impactful. So, again, I think I've spoken to most of this. We provide education as well because we're looking at health, not only health literacy, but we utilize the trans-theoretical model, but we look at it with a little deeper lens because if someone's, for example, pre-contemplative or contemplative, why are they contemplative? Is it because they have some underlying psychiatric disease or condition that is preventing them to move from contemplative to planning? Possibly. And that's the additional lens that we look through when we manage these and coach these members. Again, I've already mentioned that these are licensed behavioral health clinicians who utilize the cognitive behavioral motivational interviewing techniques using our biopsychosocial model. The physician oversight, let me just real quickly say that's very important because it's not only providing support and guidance to our coaches, but our docs also provide consultative support to the attending physicians. Imagine the primary care physicians who are struggling with these patients with multiple physical illnesses. These patients are a handful for these docs, and they can't get them to respond. They can't get them to adhere to the treatment plan. Now we've got an opportunity for one of our docs to say, oh, your patient, Dr. Smith, is enrolled in our program. We've discovered that they have a very high PHQ-9 score. We see that you haven't even made a diagnosis of depression. Would you consider looking at that? Not that we're driving that, but we're wanting to make that physician aware of the possibilities. Now we've got an opportunity for a doc to make a more accurate diagnosis and code that more accurately and treat that patient, which is going to do a lot of things, not to mention more accurate definition of risk scores for that individual. So I think I've already gone through this. These are just examples of the types of tools. Dissonance is one of my favorites because it's like using a crowbar to make a behavior change. It's using leverage. It's using the opportunity to identify someone's goal that they may have in life that's clearly, there's a barrier in front of that goal that's around a needed behavior change. So the coach very wisely and very skillfully uses this tool to change the person's perspective on their goal and gets some realization around what the barriers are to induce behavior change. So again, we have here the summary. We need to identify readiness for change in this population, identify who we are highly suspicious of in terms of having underlying psychosocial issues, identify the specific problems, implement the motivational interviewing, cognitive behavioral interventions, monitor that progress, and then eventually graduate these members from the program. It's my belief that some members need a little longer time, some need a little less time, depending on their complexity. One thing that we need to do is move members beyond at some point in time because there's a point of maximum benefit that we realize here.